This is Alyssa Chenault from UCAN, Ohio, and I'd like to welcome you today to Children's Dental Coverage and the Affordable Care Act webinar. We want to thank you for joining us. And this webinar is being presented by Dental Access Now in accordance with UCAN, Ohio and Community Catalyst. We've got some great experts on the phone with you today, but before we get into that, I'd like to go over a couple technical things that we have going on today with this GoToWebinar service. So on the next slide, it has a screenshot of all of the features that you see on your GoToWebinar toolbar. You'll see the red arrow that minimizes and maximizes the GoToWebinar toolbar. You can click that to open and close the questions box if you'd like to type in some questions throughout the webinar today. The green button mutes and unmutes your microphone. That's if you're using the GoToWebinar service through your computer. If you'd like to raise your hand, because we really want to make this webinar as interactive as possible, raise your hand, and if you have your audio feature through your computer set up through a microphone, we can have a dialogue. Or if you've used your telephone, you'll see on the audio section of this toolbar, you'll click telephone, and you'll have to enter an audio PIN that will enable us to chat over your phone. If you're on your computer, you're able to use your microphone and speaker set to speak to us to have that discussion part. So just select whichever option you'd like to use today. The best audio quality is through your telephone. If you're having any technical difficulties, please use your telephone service. And then finally, the questions tab, you can, at any point, if you have any questions about anything our speakers are talking about, feel free to submit any questions in the questions box, and we have some set up places where we'll be taking questions for this webinar today. So I'd like to go ahead and introduce David Mayware. He is our project director of Dental Access Now, and he's going to give you a brief overview of what the Dental Access Now project is and introduce our presenters today. David?
Thanks, Alyssa. Can you hear me okay?
Great.
Good. My name is David Mayware, and as Alyssa said, I'm the project director for Dental Access Now, a project of UCAN, Ohio. And we've been working for 3 years to take a look at the issues of access to dental care here in the state of Ohio and to begin making recommendations about how to change the workforce so that we get additional dental professionals into Ohio's 80 health professional shortage areas. We have identified many different problems that go along with the lack of access to dental care, including impacts on your overall health. And so today what we wanted to do was take a look at the way that the pediatric dental benefits are going to be taking place under the Affordable Care Act. With us today we have Colin Rusch. He's a senior policy analyst with Children's Dental Health Project. And Colin gave a presentation to the Ohio Consumers for Health Coverage last year about the essential health benefits and tried to help us understand a little bit more about what's coming down the road for us. And then we also have Eva Marie Stahl, who is the New England Alliance for Children's Health Project Director with Community Catalyst. And Eva wrote a blog called Healthy Teeth, Healthy Kids, making sure families can afford pediatric dental benefits under the ACA, which is at the Health Policy Hub at Community Catalyst. And that was published July 23rd of this year. So if you go onto the Community Catalyst website, you can see that blog. So today what we have are two very knowledgeable experts on this issue. And without further delay, I'd like to have them go ahead and start.
Great. Can you hear me?
Yeah.
Yep, sounds good.
Great. So good afternoon, everyone. My name is Eva Stahl, as David said. And for those of you that don't know me, I am with Community Catalyst. We are a national nonprofit health advocacy organization, and we support many states, including Ohio, with the implementation of the Affordable Care Act. So at Community Catalyst, I lead up the kids' work, which is also referred to as NEACH, and we focus on children's health and how it's integrated into the Affordable Care Act. So clearly, you can flip the next slide. Clearly, pediatric dental is a really important piece of all of that, and we are really excited to be able to work with CDHP, and you'll hear more from them in just a minute. So today we are going to Colin and I are going to take some time to first I'll do a quick overview of the essential health benefits in the Affordable Care Act, just to help frame the conversation, and then Colin's going to take you for a deep dive into some of the pediatric dental benefit, technical issues, and the barriers to implementation. And then I'll circle back and we can talk through some of the advocacy steps that things that advocates can do to really ensure a robust dental benefit in their state. So next slide. So let's step back a minute and briefly remind ourselves about how we got here in the first place. So the Essential Health Benefits Package includes 10 categories of care. One of these is pediatric services, including oral health, which is a big win for the advocacy community and families and children. The process, however, in how we operationalize getting there turned out to be less than transparent and a little bit confusing. Instead of the federal government selecting the benefits for a national baseline, they decided to defer to states and give them flexibility, and there were a variety of reasons for this, ranging from cost to the political environment. But at the end of the day, what we essentially have are 50 different essential health benefit benchmark packages. So after this complicated process of making sure the selected EHB fulfilled their 10-category responsibility, of which oral health care is one, many states, this process included selecting a benchmark, and then if there were holes in that benchmark, they would supplement it. And many chose the federal plan for dental. And Colin will talk more about that in just a minute. Now, on a side note, because I do kids work, I just want to point out that these plans are based largely on small group health insurance plans that typically do not serve children, but rather served individuals. And the decision to do this has really concerned the children's healthcare community and advocacy community because we're concerned about the appropriateness and the robustness of coverage for kids. So turning back to the EHB, it really applies to all small group and individual markets in 2014. And this summer, SOCIO published a list of plans for each state, including dental and vision, along with information about habilitative care, which is another of the 10 categories. Next slide. So now with this work, most of the work behind us, some states chose not to participate in this process, and so they did something called default to the largest small group plan, and the supplementing was done by SOCIO. But now that these benchmarks are set, it really has presented a little bit of a challenge, and this will vary, of course, whether or not you are federally facilitated, marketplace, exchange, or whether you're a state-run exchange. It's difficult because in the statute, standalone dental plans are allowed to offer plans in the exchange. Colin will talk more about this in a minute. But because of this separateness from the larger health plan structure, there are a series of challenges around how it's implemented. So these issues really include the affordability of plans when they do not sit inside the larger health plan structure or plan, and there are also include affordability as well with respect to how premiums are calculated. And there's also another problem, which the family simply may not purchase the product because it's separate. And this could really impact access for kids, which was the original goal of the Affordable Care Act. And then we also have concerns about the robustness of the benefit when it actually is offered. So I think I'm going to just turn it over to Colin and let him sort of walk you through some of these technical details and more specifically the challenges related to the implementation.
Thanks, Eva. I don't know, did we want to pause there for a second and see if anybody had any questions about just kind of the process leading up to where we are now?
Sure. If anyone has any questions, please submit them in your questions box or raise your hand, and I can unmute your line, and you can talk directly to us and ask your question. So far, I don't have any hands raised or any questions submitted.
All right, so we'll go ahead and move on, and if a question does arise, then we can pause and address that. I just wanted to make sure we had ample opportunity. So just a quick note about the Children's Dental Health Project, which is where I come to you from. We are a national nonprofit organization. We're a policy and advocacy group with the mission of really finding solutions to achieve oral health for all children. We do this by kind of looking at solutions that not only address the overall disease burden and work to reduce that, but also in terms of improving access to care and ensuring that that care is of the highest quality possible. So a little bit more about how children get coverage under the ACA. This is a flow chart that we developed with the Georgetown Center for Children and Families. And it looks a little bit hard to digest at first, but really what this shows is that starting in 2014, the children that are currently eligible for Medicaid and CHIP will continue to get their dental benefits through those programs. Depending on a family's situation, it's whether or not they have an offer of affordable coverage through an employer. They may or may not be able to purchase coverage through the exchanges. And according to the family's income level, they could qualify for tax credits to support the purchase of health coverage. Now, there's one thing I want to point out real quick, and it's that kind of in this lower right-hand quadrant, there's still a possibility that we could see children whose parents have health coverage through an employer, but are relatively low-wage workers. So they've got what under the law would be considered affordable health coverage, but they might not have an offer of dental coverage. If these kids are at CHIP income eligibility levels, the state actually has the option under the CHIP Reauthorization Act of 2009 to provide them with dental coverage through CHIP that wraps around the employer-sponsored health coverage. Right now, Iowa is the only state that's taken up that option, but I think moving into the next couple of years, this will be something to keep an eye on to see how many kids fall into that gap and whether or not it's something that states need to consider taking up. So as Eva mentioned, pediatric dental is part of the essential health benefits that have to be offered in the new state marketplaces, as well as the small group and individual markets outside of the exchanges. And it's determined by these state-selected benchmarks. For the most part, with the exception of Utah, the pediatric dental benefit offered through the essential health benefits in every state is either the dental benefit in the CHIP program or the dental benefit offered in the largest plan in the federal employee supplemental coverage program. So it's really one part of a comprehensive children's benefit, or it was intended to be. As Eva mentioned, standalone dental plans, which is where we most often get our coverage today for dental, these plans are required to be allowed to participate to offer this coverage in the marketplace. However, if they do, the health plans are actually exempt from the requirement to provide pediatric dental coverage. And this presents some issues because the law itself treats health plans and dental plans a little bit differently, and I'll talk about that in a minute. So this is just a kind of a breakdown of what the various permutations for offering dental coverage in the exchanges is. So as I mentioned, we could have a health plan that includes pediatric dental really as kind of an integrated benefit in that insurance product, and we call this an embedded dental benefit. More often than not, we see standalone dental plans that are sold separately as distinct products from the health plan itself. And it's also possible that we could see health plans contracting with dental plans to kind of offer a bundled product that is maybe sold under one premium but is effectively two separate plans. Now, in Ohio, where we're dealing with the federally facilitated marketplace, we're not going to see this, at least not in the first year. We'll either see health plans embedding the dental or folks purchasing dental coverage through standalone dental plans separate from their medical. So what are some of the potential impacts of the ACA? First of all, the main one, obviously, is expanding coverage to kids. This is from an analysis conducted by Milliman for the ADA's Health Policy Resource Center that shows that if all goes according to plan, we could have as many as 8 million kids receiving dental coverage as a result of the ACA, whether it's through the exchanges, through gains in employer-sponsored coverage, or just as a result of more people enrolling in Medicaid. On the right, we're also seeing some significant increases in adult dental coverage potentially if all states take up Medicaid expansion and there's the potential for adults to also purchase dental coverage in these new marketplaces, although it's not part of the Essential Health Benefits package. So where it really gets kind of complicated and where we really start to see that the ACA is a bit of a sausage-making process is in the kind of the regulations subsequent to the law itself and how it's implemented at the state level. So it does get kind of complicated. But the major reforms that the ACA makes to dental coverage are A, it sets distinct limits on how much an individual or a family has to pay out of pocket for their coverage, whether it be medical or dental. It allows for the standalone dental plans to have a separate out-of-pocket maximum in addition to the out-of-pocket maximum that's placed on medical plans. And this does complicate things a little further in that, if a family purchases medical coverage and then standalone dental coverage, they could possibly have an overall out-of-pocket maximum that's higher than what the law really intended. So what the feds have done is for the federally facilitated marketplaces like Ohio, that separate out-of-pocket maximum for dental plans is set at $700 per child or $1,400 for families that have more than one child. States setting up their own exchanges really kind of have a lot of leeway in determining what's a reasonable out-of-pocket maximum for standalone dental plans. The law also removes annual and lifetime limits from coverage on medical and dental. And this is really a big issue for dental because traditionally what we've seen in dental insurance is really more of a defined benefit where you kind of have a set plan structure and an annual limit of, say, $1,000 or $1,200. And after that point, you're on the hook for the rest of your services. It also makes available child-only plans because pediatric dental is really the only dental product that is subsidized through the ACA. It sets some vague requirements for network adequacy, and I'll talk a little bit about that later on in the presentation. It also requires, at least in the federally facilitated marketplaces, that plans contract with what we're now calling essential community providers, and these could be things like community health centers or FQHCs to really kind of extend the networks of health plans in areas where we're seeing a lot of underserved individuals and families. There are some quality reporting requirements which have been pushed back to 2016, so we have some opportunities to work on that. And as we all know, there are premium tax credits now that are available to families up to 400% of the federal poverty level to help them pay for the cost of purchasing coverage. So some of the complicating factors here, and this was the least gross picture of sausage making I can find, so you can thank me for that. So some of the complicating factors are, like I said before, the regulations allow for a separate but additional quote-unquote reasonable out-of-pocket maximum for standalone dental plans. And this differs a bit from the out-of-pocket maximums that the law sets for medical in that it doesn't vary according to a family's income. So a family at 250% of federal poverty level would have the same out-of-pocket maximum for their dental if they purchase it through a standalone plan as a family at 400%. As Eva mentioned, there's really no requirement to purchase dental coverage in the exchanges if it's offered separately, and that's really just kind of a result of the way that the language of the law played out in requiring that standalones be allowed to participate but also exempting the qualified health plans. So there's really no enforcement mechanism to ensure that families purchase standalone dental coverage unless the state itself sets that requirement. The cost-sharing reductions that the law develops, which really serve to make sure that low-income families don't pay significant amounts of money out of pocket for the cost of covered services. And this applies to families up to 250% of federal poverty. So in Ohio, where CHIP income eligibility goes up to 300%, this isn't really a concern for dental. But it's worth noting that across the nation, that varies, and so there's the potential for kids who are, say, at 250% of federal poverty and CHIP only goes up to 200%, that those cost-sharing reductions won't apply to their dental benefits. Outside of the exchange, in the small group and individual markets, there's no such language requiring that standalone dental plans be allowed to participate. So effectively what we have is sort of a requirement to purchase. So what the regulations say is that people enrolling in a qualified health plan outside of the exchange in the small group market or the individual market have to reasonably assure their health plan that they have purchased standalone dental coverage if that plan doesn't itself offer pediatric dental coverage. And then most recently, we've come to understand that the feds are allowing a 1-year exemption for small employer plans on the out-of-pocket maximums if that plan administers different benefits through different benefit administrators. So for instance, oftentimes pharmacy benefits, even though they're part of the health plan itself, are often administered through a separate benefit administrator. And what this means is that for this first year, you might see some small group plans where they've got a out-of-pocket maximum of, say, $6,000 for an individual on the medical side, and they're applying an additional $6,000 out-of-pocket maximum on the pharmacy side, which is a real affordability barrier. And theoretically, we could see that for dental benefits, though I haven't actually seen any plan designs that do that. And again, this is really only in the small group market and for this first year. I might just pause there for a second. I've covered quite a few kind of technical issues and before I dive into the premium tax credit, see if anybody has any questions.
Okay, great. Submit any questions you have for Colin about anything you just covered or anything else about dental that you'd like to talk about. Either raise your hand and I'll unmute your line and we can chat, or submit it in the questions box and I'll read your question aloud and get some answers for you. Okay, looks like we might have one.
Okay, I'm seeing that. So what is the policy reason that those inside the exchange don't have to purchase dental? So really, this all has to do with the way that the law is written. So it says that standalone dental plans must be allowed to participate to offer the pediatric dental portion of the EHB in the exchange. It also says that if they do participate, then the health plans themselves are exempt from offering that aspect of the coverage. So potentially you could have one standalone dental plan offering pediatric dental and the rest and all of the health plans in the exchange deciding that they're not going to offer pediatric dental because enrollees can purchase it through the standalone. Now, the individual mandate language doesn't address what we call accepted benefits, and standalone dental coverage falls into that category of accepted benefits. So there's no requirement to purchase anything that's considered an accepted benefit. So what we end up with is this sort of loophole where there's no requirement to purchase standalone dental coverage inside of the exchange. Now that language doesn't exist outside of the exchange, so what the feds have done is kind of said one way or another you really have to have pediatric dental coverage outside of the exchange, although we haven't really figured out how that's going to really play out practically.
And this is Eva. I mean, I can just comment on what's happened in Massachusetts, too. I mean, in Massachusetts, we just have standalones being offered in the exchange. And so they actually recently just pushed forward legislation that if you're outside the exchange, you get asked, do you have dental insurance? And if you say no, then they say, well, we can't sell you a health insurance plan, but they can direct you to the exchange where you can purchase the exact same health insurance plan but without the dental, which we view as highly problematic.
Yeah, it's pretty absurd. Now there are states that have passed requirements to purchase all 10 essential health benefits inside of the exchange, and that's certainly an option. But you know, we've kind of avoided pushing for that until we really have a sense that those benefits are going to be affordable for families.
Okay, we have another question from Ryan, and his question is there flexibility for states to tie out-of-pocket dental maximums to income?
That's a good question. I think it's tough because, as I understand it, the way that the reductions in that out-of-pocket maximum according to income are financed is through a subsidy to the insurers themselves from the feds. So unless we see a change in policy at the federal level on this, which we are pushing for, the state would have to figure out a way to finance that.
Okay, we got one more question from Kathy, and she asks, Ohio's CHIP program only goes up to 200% of federal poverty line. Can you repeat what that means for access and affordability to kids' coverage?
Oh, my mistake. So I was under the impression that it went up to 300%. So if Ohio's CHIP program only goes up to 200%, then that means that we could have kids between 200 and 250% of federal poverty who are getting standalone dental coverage through the exchange, and not on the medical side, the amount of money that they have to pay out of pocket for each covered service is reduced. So what this effectively does is it increases the actuarial value of their coverage on the medical side. So let's say they're purchasing a silver level plan, which is its 70% actuarial value. It might bump that up to like 87%. I don't remember exactly the adjustments that it makes. So that they would only be responsible for 13% of the cost of covered services. On the standalone dental side, that wouldn't apply. So they would be responsible for the amount or the percentage that is outlined in the plan as is.
Okay, that's all the questions we have right now.
Okay. So quickly, the law finances or helps families purchase coverage through premium tax credits for families up to 400% of the federal poverty level. The law does say that the pediatric dental portion is that the tax credits do apply to that. The way that the tax credits work is that the tax credit goes to the insurers on behalf of the people enrolling in the coverage. And with regard to people buying dental and medical separately, it goes first to the medical plan, and then if anything's left over, it goes to the dental plan. However, because of the way that the tax credit is calculated and the way that the IRS is interpreting the law, there's a real possibility that people purchasing standalone dental coverage won't get enough tax credit to support the purchase of that coverage. Because the tax credit is calculated based on the second lowest cost silver plan available in the marketplace, which may or may not include pediatric dental benefits. And if it doesn't, then the amount that the family gets is only based on the cost of medical coverage. So what we've been advocating for and what we think that the law and the regulations allow is for them to combine the cost of medical coverage and standalone dental coverage in order to calculate that tax credit amount. So we've submitted a memo to them. We've sat down with them and discussed this issue. They seem open to addressing it, but they're kind of at a loss for what the avenue is. Right now, our next step is a legal memo that will be submitted to them to kind of help them understand what options they have. But we really do think that it doesn't require reopening the law or really even reopening the regulations to fix this issue for families, which is not an insignificant problem. And again, the law implements a number of market reforms and consumer protections aimed at ensuring that families are treated equally no matter how they purchase their coverage. Unfortunately, again, because of the way the law is written, a number of these consumer protections don't apply to standalone dental coverage, including protections against denial for pre-existing conditions, guaranteed issue and renewal of coverage, fair insurance premiums that are based only on age, geography, and tobacco use, guaranteed premium rates. So when a family sees a rate during the enrollment process, that rate wouldn't change. But for standalone dental, there are some adjustments that can be made after the fact. right to an external appeals process, and finally medical loss ratio, ensuring that 80% of the premium is spent on treatment. Now, states themselves have flexibility to impose these requirements and more on health plans and dental plans, but at the federal level, this is kind of the way that it plays out. So some of the implications of this regulatory approach: we do have relatively comprehensive dental EHB benchmarks. There's some standardization efforts between the state-based exchanges and the federally facilitated marketplaces. But these out-of-pocket maximum issues that I just discussed, as well as the tax credit issues, certainly pose some significant affordability barriers that we're going to continue to try to fix, if not for 2014, for the out years. And it raises a number of questions about how we convey all of this information to consumers as they attempt to enroll in coverage in 2014. So some of the outstanding issues are, like I said, really making sure that consumers understand what benefits are available to them and educating them on the complexities of that. So in the enrollment process, we want to make sure that it's as transparent as possible in conveying how much coverage really costs, what their expected out-of-pocket costs can be, how much they're going to get for a tax credit, and whether or not that's going to help them buy dental coverage, and really addressing some of these network adequacy issues, like how many essential community providers will be available to them depending on the plans that they purchase. And looking forward to 2016, how can we address issues like quality measures and reporting standards to make sure that families who are getting coverage and who are getting care are getting the care that they really need. So this is just kind of a list of things that, as groups like yourselves work with families and other advocacy groups to enroll them in coverage, that families need to really be factoring in when they're considering their various purchase options for pediatric dental coverage. So a couple of things that you should be doing is really asking the questions to those who are implementing this in Ohio about some of those outstanding issues and how they plan to address them. Engaging consumers and consumer outreach groups to make sure that they really are including these dental issues in things like navigator training and other consumer outreach efforts. And finally, monitoring how all this really goes down in the next year or so. So what's being offered in Ohio, who's getting coverage, and why or why not? So what are some of the barriers to enrolling in coverage, whether it be just confusion about the complexities of dental coverage, the affordability issues, and maybe whether or not they actually need it. So I'm going to hand this back over to Eva so she can talk a bit more about strategies for advocates.
Sure, but before we do that, do you want to just see if we have any more last round of technical questions before we move forward?
Yeah, I think that's a good idea.
Sure, so submit any questions you have in the questions box or raise your hand and I'll unmute you and you can ask your question over the phone or over your mic on your computer and we'll get them answered for you.
And I'm happy to repeat anything.
All right, doesn't look like any questions yet.
All right, so Colin covered a lot of really great information, and he had a really great list of things that are important for advocates to do. I think it's also important to take a step back and think about what your strategy is as advocates. You know, in a lot of states that we've worked with, particularly, that there's been, you know, if you've been a part of the EHB process from the beginning, a lot of groups really came together to try and reach consensus about what needs to happen to ensure that their state selected the most robust benchmark possible. I think that those coalitions and those tables still play a really important role. And so, you know, one strategy is to really, if you haven't been at that table, to find out what, you know, what's happened to that table or has it been absorbed into another. The most logical place for it to be absorbed would be groups that are focused on outreach and enrollment. And the reason for that is that really the strategy over the next year or the next two is to really build a narrative. And the reason to build a narrative is because the essential health benefits package is not it's not final, that it will be reviewed at the end of 2015 for renewal in 2016. And so really for advocates, this is an opportunity to really showcase where the essential health benefits package has and has not worked. So for dental, I think particularly for the dental benefit, that's a prime opportunity hopefully to fill some of these holes and correct some of the issues that Colin outlined. But it's a lot of work of that, in between to build that narrative. And I think that a lot of the work that can be done that he referred to, sort of gathering information and gathering stories, are an important piece to that. I can give you an example. We work with Rhode Island, and they've worked very closely with their insurance department to sort of think through how to track whether or not there will be take-up of the dental benefit inside the exchange. So it's the hope, after some good advocacy, we'll have our fingers crossed, that we can get the exchange to actually incorporate this kind of data collection so that we can better understand if families are actually going to bypass the purchase of dental because of perhaps fears of affordability, that they don't want to take on a second premium. And so that's one strategy for data collection. And of course, the other is to work with other partners, like dentists and dental insurers, because they want people to take it up too, to better understand what kind of take-up is actually happening over the next year. Certainly another important player in strategy is to engage your insurance commissioner. In some states that's more challenging than others, but there are certain requirements placed on the Department of Insurance and the insurance commissioner with certifying essential health benefit plans. And while with the federally facilitated exchange, we don't really know what those look like quite yet, we do know that they have to go through the state in order to be certified. So as much as you can or are able to continue a conversation with your insurance department or your insurance commissioner in a positive way, that's a good thing. And then the other thing that Colin talked about was about educating consumers, because this is incredibly complex. I mean, even when you just try to understand how it changes both inside and outside the exchange, it's very difficult to explain. And so part of that is making sure that your outreach and enrollment table, as well as your navigators, are really knowledgeable about your state dental benefit and how it's going to be presented. And so having a really good grasp of that information so that it can be easily explained to consumers will play a really important role. And finally, the whole kit and caboodle is to monitor. It's to monitor consumer experience and advocate for more transparency as we move forward, as Colin alluded to. Just because there are so many difficult twists and turns of trying to understand this benefit, trying to make sure that consumers actually have access to it is so important, particularly because we want all these kids to be able to have access to this great benefit. And so those are just sort of some general ideas and strategies to think about. And I think that, Colin and I would love to hear some experiences and ideas that you all have had in your states about things that have worked and things that haven't, or brainstorm a little bit about different opportunities. And so with that, I'll turn it back.
Okay, thanks. I think while we wait for some questions, comments, some discussion thoughts from things that have worked in other states, brainstorming ideas, we'll turn it over to Kathleen Gemeiner, who's Ohio Consumers for Health Coverage Project Director, and she's going to talk about what's going on with Ohio as far as implementation and essential health benefits. Kathleen?
Thank you, Alyssa. Yeah, what I will say about Ohio is fairly short. I am not aware, doesn't mean there aren't any, but I'm not aware of plans in Ohio that actually have the dental benefit in the exchange. And that's because there is a freestanding benefit available, and I've been making some efforts to find that out, but at this point I don't know of any plans in the exchange that offer the dental. If any of them would, my guess is it would be CareSource, because they, as a Medicaid provider, have dental benefit and would have done all of the legwork involved in getting that in place. But I can't confirm that. Now, for the ones off the exchange, my understanding is that because the the consumer has to provide the reasonable assurance that they have dental to get a plan without dental, that they are planning, the plans are planning to provide the dental benefit, and they're doing it by partnering with other dental carriers. So other than saying that, which is a pretty, painting Ohio with a fairly broad brush here, that's really all I can add at this point about Ohio.
Okay, thank you, Kathleen.
Mm-hmm.
So I just want to kind of follow up on that in saying that, we've talked a lot about standalone dental plans and kind of the complexities with that. But, in terms of educating consumers, even when a dental benefit is part of the medical plan, they need to be aware of how that plays out in terms of some of these affordability issues, especially with regard to deductibles. So depending on how that plan is structured, the pediatric dental coverage may or may not be subject to the full medical deductible. Now, that and whether or not that's an issue really depends on how many services on the medical and dental side the family is utilizing. But it could potentially be an affordability barrier if the family is not utilizing a lot of medical services, goes to use their kid's dental benefit, and finds out that those benefits are subject to the full medical deductible. Now, I will say in other states that I've worked with, we haven't seen that be an issue. So, for instance, Connecticut is a state I work with a lot, and the plan designs that we've seen there do not subject the pediatric dental benefits to the medical deductible. So it's really not an issue, but it's something to make sure, if you are involved in kind of consumer outreach and education, that families are paying attention to how that plays out in whatever plan they choose.
Okay, so submit any questions, discussion, things that have worked, ideas advocates can do to get involved and to make sure that dental coverage works for Ohioans. You can either raise your hand or submit them in the questions box and we'll get them answered.
Okay, so I see one question. It says, is the American Dental Association tracking what's happening in the various states regarding standalone coverage? I don't know for sure. I know that the ADA's Health Policy Resources Center has certainly taken a look at kind of the impact of the ACA. I work with a couple of folks here in D.C. from the ADA, and they are certainly kind of on top of the regulatory issues, but I don't know whether or not the ADA has a formal mechanism or plan for kind of tracking all of the state implementation efforts.
They did actually publish an FAQ, too, I actually just saw on the 19th of this week. Yeah. So I think they're definitely engaged. I think another part of it, too, is to, particularly for our, our federally facilitated exchange states are really concerned, rightfully so, about how to provide feedback, as we watch sort of the ACA be implemented over the next couple of months. So it's important to kind of figure out how that feedback loop is being set up in your state and how you can contribute to that in some way. Certainly if you're gathering stories, if you have your ear to the ground and you know what's happening, because it's important information to feed back to the Fed. And I think, too, that, Colin and I are both always open to hearing from anyone, too, that can contribute to that narrative as well, so that, we can relay those messages as well. And particularly with Colin's work as they work to sort of, try to tweak some of the regulatory issues.
Okay, I've got one more question. Are there timetables we should pay attention to nationally and in Ohio? Well, I mean, the two major upcoming events are October 1, where families will be able to begin enrolling in coverage, and then January 1, which is when coverage actually starts. So I would say, October 1 is when to really start paying attention to the consumer experience, because I think that there's, regardless of how great the state is in consumer outreach and education, there's going to be a lot of confusion. And so I think it's important to begin kind of paying attention to the enrollment process and how that's playing out for consumers and families right from the start. In the long term, I think, by 2016, I think there are plans to kind of evaluate how this is all played out and whether or not changes need to be made to the EHB. And again, kind of leading up to that, we should be thinking about what quality reporting standards really need to be implemented in the exchanges, because that will be our opportunity to address that as well. And then finally, with regard to CHIP, that will be coming up for reauthorization in the next couple of years. And I think there are a number of folks in Congress who feel like now that we have the ACA, we don't need CHIP. But I'm not as confident yet in the ACA's ability to really adequately serve those families yet, that I would say that we need to do away with CHIP. And I think right now we need to really pay attention to the interface between CHIP and the ACA in the next couple of years, and collect the stories necessary to protect that program until we are sure that the ACA is really doing what it's supposed to do.
I second that. I think that the CHIP issue is a really big deal. So if you don't already know that CHIP is actually reauthorized through 2019, but it runs out of money in 2015. And so there will be a big conversation over the next year or so about whether or not to continue to fund the program. And certainly we feel that it's very important to continue it to protect children and also to give the ACA more time to gel and to be implemented before we shift kids into the exchange, which is the most likely outcome if we end the CHIP program. But I also just wanted to add that I totally agree that October 1 and January 1 are the big dates. I think that any education or contribution that you can make to your navigators in your state and helping them really understand the pediatric dental benefit, how it works in your state, is incredibly valuable. I think that it's sometimes pushed to the side and that it's a very confusing issue for consumers, and that it's a real opportunity to educate them, particularly because it's separate and can be challenging because it's just different than health insurance as it currently stands. And then I would also argue that after that sort of consumer outreach time, that then it's really an issue, as Colin highlighted after January 1, as to how consumers are actually accessing it. And that's when we're going to really see how things play out.
Okay, we've got another question from Jesse, and he asks, in Oregon, our insurance commissioner has asked for our input on what's reasonably assurance should look like for pediatric dental outside the exchange. Do you have any thoughts about this?
So Jesse, I can send you the legislative piece from Massachusetts. I'm happy to do that. There is an ongoing debate. Colin and I actually talked about this yesterday, and my friends from Rhode Island were asking me for a definition of reasonable assurance. And I think in Massachusetts, the general understanding was that there would be a question with a checkbox, and do you have dental insurance, yes or no? So Colin, I don't know if you want to add to that.
Yeah, I think, unfortunately, it's going to be more often than not that simple. But what the regulation states is that they not only have to have reasonable assurance that the enrollee has pediatric dental coverage through another plan, but also that plan has to be exchange certified. So really, what we're talking about is making sure that family has pediatric dental coverage that meets the standards of the EHB. And short of actually submitting a plan summary as part of that reasonable assurance process, I'm not sure how you really go about doing that.
Yeah.
Well, it looks like all the questions we have right now. Do we want to do some last words and then wrap up?
Sure. Yeah, I mean, I think, again, we're really coming up on the deadline, and from the Fed's perspective, we're in kind of a pencils down mode, is what they keep saying. So I think, we've spent the past couple of years really pushing hard on policy and regulatory fixes, but at this point, I think we need to be gearing up for how to monitor this process and how to help consumers understand the enrollment process and work with the entities who are in the official capacity of educating consumers to make sure that they understand the complexities of all these dental issues.
Sorry, I was on mute. And I would just say that, it's like the 3 C's. You need to collaborate, you need to coordinate, and you need to collect. And so I think it's really important that you make sure that you're at the right table and that you're collaborating with other people that are working on essential health benefits in general, and you really coordinate your messages around dental, particularly because it's so confusing, and make sure that your navigators and other assister types in your state are giving the right information and the messaging is consistent. And then finally, as we move forward over the next year, it's all about collecting information, and that data can come in many different forms, whether it's a story that needs to be vetted or whether it's just a trend that you're hearing over and over again, and that needs to be a part of a feedback loop either to the federal government or to the exchange to let them know what's happening. And certainly I know that Colin and I are available to be supportive and to help out as much as we can, and our information should be available to you.
Yep. So I've got one more question here from, it says, how does all of what you've been saying apply to the shop exchange? So this is really where the small employers will be able to buy coverage on the exchange for their employees. And up until recently, it was understood that the employees would have some choice in that. But they're kind of delaying that component of it. So really the way that would play out would be that the employer would just go ahead and kind of choose one plan for all employees if they're purchasing on the exchange. But more importantly, because it is exchange coverage and because we're talking about small group coverage, really all of this applies, especially the piece about the out-of-pocket maximum requirements being delayed for small group plans. So while I think it's highly unlikely that we're going to see many small group plans buying coverage that includes dental as part of the medical product, if they do, we should, they should be aware that if that dental benefit piece is separately administered, then that plan could potentially have a higher out-of-pocket maximum than what the law really intends. But again, this is really only for the first year. So I think the risk of that is relatively low. I think it's probably much higher for things like pharmacy benefits, but it is something to keep an eye on.
Okay, great. Well, we'd like to thank Colin and Eva for taking time to present all this information today, as well as Kathleen for giving us a perspective on what's happening in Ohio, and also David for pulling all of us together to be here today. We'll make sure in a follow-up email that you'll get a copy of this presentation, as well as contact information for all our speakers, and also a recording of this webinar in case you know anybody who missed and wasn't able to attend. You can share it with them and also with your network. We do have a survey at the end of this webinar, so if you'd like to take some time and fill it out, that'd be very helpful. And I'll just pass it over to David to give us a send-off.
Well, again, I wanted to thank Colin and Eva for taking some time today to help us understand a really complex issue, and just to assure you that we will continue to monitor what's going on here in Ohio. And thank you for being on our maiden webinar. This is the first webinar for Dental Access Now, so we really appreciate you kicking us off.
Thank you.
Happy to be aboard.
Thanks, Alyssa.
All right. Thanks, everyone. Have a great day.